Thank you, Madalena, for these nice words, Madalena, Claudia. Ladies and gentlemen, I think it's an extremely interesting topic because the recommendations for the duration of dual antiplatelet therapy after an acute coronary syndrome has been changed in the past tremendously. So this is my declaration of interest. I would like to give you some background information. So one important point is that after an acute coronary syndrome, and if you look here over 4 years time, there's an increase in ischemic events. In red you see the average, it's about up to 20% within 4.5 years. But if you're older than 75 years of age, and if you have at least one typical characteristical risk factor, there's even a higher increase in events. So we need to do something in our patients, and the question is, should we do it longer than compared to the recent recommendations? Now, here you see the kind of events that occur. It's about 20%, as I told, and about 13%. It's an event in an already stented lesion. So this is what we expect. There could be some problems with the stent over time. But in about 12%, it's an event in a de novo lesion. So the basic disease goes on, and we need to do something about that. And the question is it only a prolongation of dual antiplatelet therapy that gives us the answer? So if we talk about the prolongation of dual antiplatelet therapy, we have done that before in clinical routine in about, I would say, 20% of our patients. This is from the Paris registry, and this is data from the United States and Europe, and it's a 2 years follow-up, but you can see clearly that in more than 5,000 patients, you can see the event rate of 11.5%, but in about 22% of patients, before we had the studies available, dual antiplatelet therapy was already prolonged. So why prolong dual antiplatelet therapy, or why shorten it? And the usual time that has been recommended over the past years after ACS, non-ST elevation ACS, is 12 months. So a short-term DAPT is favored to reduce major bleeding. So in patients with an increased bleeding risk, we will also see over time an increase in severe bleeding complications. And we have this data from several trials as shown on the upper part of the slide. On the lower part, you see when how a prolonged dual antiplatelet therapy is explained, is favored to reduce ischemic events. So it's mainly stent thrombosis that has been investigated by essentially the same trials. So we know prolongation, we reduce stent thrombosis, ischemic events, shortening, we reduce potential bleeding complications. So what do the guidelines tell us? And these guidelines are from 2015, so they have been published in the written version 2016. And what you can see here is that the P2Y12 inhibitor, in addition to aspirin, is recommended for 12 months, unless there are contraindications or other ideas. And the same guidelines tell us long-term P2Y12 inhibition should be done as, in patients after careful assessment of ischemic and bleeding risk. It's clear. A patient with an increased bleeding risk wouldn't get a prolonged dual antiplatelet therapy. A patient with an increased ischemic risk would get it. And the shorter administration of dual antiplatelet therapy in these guidelines has been discussed for 3 to 6 months. But what we have meanwhile is also data for only 1 month, and I will come to this a bit later. So we have to weigh ischemic and bleeding risks. So this is clear, and we have to do it on an individual basis. We have some data. This is post-hoc analysis of the Prodigy trial. And they looked at bleeding risk status, and they looked whether this is a treatment modifier for dual antiplatelet therapy in this Prodigy trial. And they looked for certain variables that like lumen narrowing or an anatomical situation that the intervention was performed in the left main and or the proximal LAD, whether this is also a modifier with respect to the duration of treatment. And what they found, and this is with respect to bleeding risk, patients who had a crusade bleeding score of more than 40, and this is the red line, and they had a long dual antiplatelet duration of 24 months. They had an extremely increased bleeding complication rate. So if patients had a short dual antiplatelet therapy, but a high bleeding risk, as shown in the dotted red lines, so this risk came down, and you see in the blue lines, this is patients with a low bleeding risk. So here it doesn't, with a low bleeding risk or increased bleeding risk, if you reduce dual antiplatelet therapy, this is a good idea and doesn't put harm to your patients. And here are the data. This is definitive or probable or possible stent thrombosis. So all of these different variables in the landmark analysis. And it shows you that if you treat patients for 24 months with dual antiplatelet therapy, this might have a positive effect with respect to left main or proximal LAD lumen narrowing. And if you don't have it on the right-hand side, there is no difference. So if there's a specific anatomical problem, a prolonged therapy might be of interest, but only if the patient has a low bleeding risk. So what can we say with respect to prolonged dual antiplatelet therapy? Long-term antiplatelet therapy might have a favorable effect on latent violate stent thrombosis and on the natural course of coronary patients in whom events are also caused by progression of systemic atherosclerosis. More potent antiplatelet drugs are available and used in clinical routine now. Their positive effect has been tested for long-term use, and we have especially data, prospective randomized data for ticagrelor with this aspect, and I come to this in a minute. And prolonged dual antiplatelet therapy should not be offered to patients with increased bleeding risk. Two studies I would like to mention with respect to prolonged dual antiplatelet therapy. So this is data from the DAPT study from the United States, and here clopidogrel in association with aspirin was used either for 12 months or for 30 months. And what you see here is the co-primary effectiveness endpoints like definite or probable stent thrombosis, definite stent thrombosis, MACE rate, and myocardial infarction. And here you see a clear benefit of the prolongation of treatment with respect to placebo. There's only one hint in this analysis that there was a slightly increase in all-cause mortality. So this is a bit difficult to explain, but it's the only study that showed that there might be an increase in mortality, eventually based on bleeding complications, but this is not quite clear at the moment. And here you see the primary severity endpoint, moderate to severe bleeding, moderate bleeding, BARC type 2 or BARC type 3 bleedings, and in all these patients, a prolonged dual antiplatelet therapy was harmful. So we really need to look at the patient, at the ischemic risk of the patient and the bleeding risk, and then we can decide to prolong therapy or not. Much more interesting data have been published in the Pegasus TIMI 54 trial, and here you see the design. Ticagrelor was used either with 90 milligrams twice daily, the usual dosage we use now, or with 60 milligrams twice daily, always in addition to aspirin. And the third group was aspirin, prolongation therapy of aspirin with placebo. So here patients were including who had an acute myocardial infarction 1 to 3 years back. And after stopping of dual antiplatelet therapy, so patients could be included into this trial. And then they received one of these 3 treatment arms. So the question was, is it helpful to prolong dual antiplatelet therapy with 2 different dosages of ticagrelor? There have been some exclusion criteria, and this is exactly patients who should not be treated with a prolongation of dual antiplatelet therapy, especially with ticagrelor, which is patients who have coagulation disorders, a history of stroke, CNS tumors or intracranial vessel anomalies like aneurysms. GI bleed within 6 months or severe surgery within 1 month was also a contraindication, as was bradycardia or the risk for bradycardia, as we know that ticagrelor might add here, and patients might need the pacemakers if this would be really a problem if you aggravate bradycardia. Severe liver or kidney disease was an exclusion criterion, as was patient on severe on dialysis, and patients with a planned therapy of P2Y12 inhibitors or other anti-thrombotic agents. Here you see the outcome data. So patients on 60 or 90 milligram ticagrelor twice daily had a benefit with respect to a combined primary endpoint compared to aspirin alone, as shown on this slide. There was more bleeding complications with a 90 milligram dose So finally, the 60 milligram dose has been approved now by the EMA and also in the United States for the prolongation of therapy. And this is the on-treatment analysis of the primary endpoint, cardiovascular death, MI, stroke, and then of single endpoints like death, MI, and stroke. And you see there's a benefit of prolongation of therapy with ticagrelor, and this is data from the 60 milligram dose that is approved at the moment. So this is for patients who have no increased bleeding risk, because if you look at the severe bleeding complications, they increased. TME moderate and TME severe increased, not the fatal bleedings like intracranial fatal or a combination of both, but all the other bleeding complications increased. And if you look in this study just to the number needed to treat and number needed to harm, it's about 80. So if you look first on this data, you would say there's not much difference, but the difference comes from the right patient. So the patient with a low bleeding risk and a high ischemic risk. This patient might benefit from this treatment. So in Austria, we just published a paper just for our Austrian colleagues, and which patient should have a dual antiplatelet therapy of 12 months or less. This is a patient with a history of bleeding and increased bleeding risk. Maybe it should be really less than 12 months. A history of TIA or stroke, a permanent need of oral anticoagulants or NSAIDs, frailty, cancer, and chronic kidney disease in the stage 4 to 5. Other patients with a prolongation of therapy are patients with a history of stent thrombosis, of re-MI, complex coronary anatomy, complex coronary intervention, diabetes, peripheral artery disease, or chronic kidney disease in stage 3. Excuse me. Most importantly, if you plan on an individual basis to prolong dual antiplatelet therapy, you should plan it very early. Eventually, you plan it when you start treatment with dual antiplatelet therapy. If you have a patient with a complex lesion, if you have a patient with a typical history of recurrent MI, for example, and low bleeding risk, you could define a prolongation of therapy up to 3 years after the first phase of dual antiplatelet therapy. So you could say after 12 months, you should prolong dual antiplatelet therapy because this patient has a specific ischemic risk and low bleeding risk. And this has been learned from the Pegasus trial, because only patients who were switched from aspirin monotherapy within 1 month of stopping the original dual therapy had a huge benefit. There was still a benefit up to 1 year, from 30 days to 1 year. But patients who are on a chronic aspirin therapy more than 1 year after myocardial infarction eventually don't benefit from a prolongation at all, because they are completely stabilized. But so this is the interpretation we can give with respect to this data. With respect to a shortened dual antiplatelet therapy after non-NSTE-ACS, 1 up to 3 months, relatively short. So we should do that in patients with a really high increased bleeding risk. Clopidogrel eventually might be preferred over prasugrel or ticagrelor, as bleeding complications with clopidogrel are usually lower. And guidelines that are back 1 or 2 years tell us that second generation DAS are at least as good as bare metal stents and could be used, should be preferred, as usually bare metal stents were preferred in patients with an increased bleeding risk. Now we have data. We have data that 1 month might be enough, also in patients with acute coronary syndromes. And this is a post-hoc analysis of the CHOICE trial in more than 800 patients. And they looked at patients with an increased bleeding risk based on these criteria, age more than 80 years, an indication for oral anticoagulation, other prohemorrhagic medications, recent bleeding episode, or known anemia. And they compared a drug-eluting stent, and then an Endeavor stent, sirolimus-eluting, with a bare metal stent, and found that the primary ischemic endpoint, death, MI, or target vessel revascularization, was significantly lower in the drug-eluting stent. So it's not equal. It's even better to use a drug-eluting stent of the second generation in patients with an increased bleeding risk, even if you have only a 1 month dual antiplatelet therapy, and this includes also ACS patients. And this is stent thrombosis. To some extent, surprisingly, it was lower in drug-eluting stents of second generation compared to bare metal stents. There's also one prospective randomized trial from statistical point of view, I think more interesting, the LEADERS-3 trial. Here the BioFreedom drug-eluting stent was compared to a bare metal stent in 1,200 patients in both groups. Here again, the increased variables for the varies for an increased bleeding risk, and most patients had at least two of these variables. More than 65% were elderly patients older than 75 years of age. The new P2Y12 inhibitors were only used in a very small percentage based on the recommendations that clopidogrel should be used in patients with a high bleeding risk. And this is one of the endpoints, primary efficacy endpoint, clinically driven target lesion revascularization significantly reduced in the drug-eluting stent compared to the bare metal stent. These data have been also investigated for ACS patients alone. It shows exactly the same with a bit higher complication rates, and it has also been evaluated for the elderly, more than 80 years of age. And also these patients benefit if they receive only 1 month of dual antiplatelet therapy, if a specific stent is used. In this case, it was a BioFreedom stent. So this is my summary slide. We need an individualized strategy. Current guidelines still recommend 12 months after ACS independently of treatment strategy, type of stents, or type of P2Y12 inhibition. The benefit of the new P2Y12 inhibitors, especially of ticagrelor, has been shown for an extended use of these agents after ACS in patients with high ischemic and low bleeding risk. Patients with anatomical high-risk situation like left main or proximal bifurcation, or high risk for arthrothrombotic events, patients with recurrent MIs might benefit from an extended dual antiplatelet therapy, and shortened dual antiplatelet therapy, 1 up to 3 months, can be performed in patients with high bleeding risk by use of special last generation drug-eluting stents.